Welcome to Unit 6 on substance-related and other addictive disorders. I chose this as one of the chapters to cover in this course because substance use disorders are common and have a huge impact on our communities. The U.S. ranks low on education but high on substance use problems. We live in the most addicted adult cohort in U.S. history. Substance use disorders affect people from all walks of life, but they are treatable, and many people do recover. Many individuals in treatment settings have co-occurring disorders. Co-occurring refers to having both a mental disorder and a substance use disorder. About half of those who walk into a mental health clinic will also have a substance use disorder, and about half of those in substance use treatment centers will also have a mental disorder. Substance abuse is the excessive or harmful use of drugs or alcohol. And it is important to remember that alcohol is a drug, a psychoactive drug. Alcohol alters mood and thought processes. Now, because it is legal, I think the fact that it is a psychoactive substance is overlooked. I remember reading an article written by a psychiatrist who said that if alcohol was presented as a new drug today, it would never get FDA approval. And just consider what you would list as the dangerous side effects of alcohol. About 8.5% of the population met the criteria for substance use disorder in 2012, and alcohol is the most commonly abused substance, followed by marijuana, pain relievers, and cocaine. Prescription drug abuse is a major problem in America. The most prescribed medication today is hydrocodone, a synthetic opioid which is a prescription pain reliever. Why is alcohol and other drug use such a major problem in our society? Well, we tend to look for quick fixes, and a Chinese proverb may give us some additional insight. The proverb says, "It's easy to get 1,000 prescriptions, but hard to get a single remedy." Substance-related disorders arise when psychoactive substances are used excessively. The term addiction is used when there is compulsive drug-seeking behavior and loss of control over drug use. Also, withdrawal symptoms occur when use is stopped, and withdrawal symptoms can be quite severe. I don't think I've ever quoted Keith Richards of the Rolling Stones in a lecture before, but he said it well when talking about withdrawal. He said, "I only get ill when I give up drugs." Loss of control is a major sign of addiction. For example, a businessman may stop at a bar after work for a drink or two and sincerely intend to limit himself to 2 drinks, but he ends up leaving at 2 a.m. It's as if the shut-off switch has broken. Loss of control is perplexing, as sometimes individuals can control their use, but overall, use is unpredictable. All drugs of abuse target the brain's pleasure center. All drugs of abuse directly activate the brain's reward systems by flooding its circuits with dopamine. This flood of dopamine creates the euphoric effects that lead abusers to repeat the behavior in order to repeat the experience. Drugs are more addictive than the natural highs produced by other things we like, such as eating, listening to music, or having sex, because the drugs cause far more dopamine to be released, anywhere from between 2 and 10 times as much. Now, this flood of dopamine results in an eventual dopamine depletion. Research has focused on the dopamine pathways to provide an explanation for compulsive drug-seeking behavior and the physiological dependence on substances of abuse. Over time, the neurons in the dopamine pathways downregulate in response to surges in dopamine, meaning they produce less dopamine, or they reduce the number of dopamine receptors. Users then need to take drugs to raise the dopamine levels back to normal and deal with withdrawal. In order to experience the effects initially experienced from the drugs, they need to take higher and higher doses, which is called tolerance. Classical conditioning and having a predisposition have also provided some explanations of substance use disorders. Because users associate the pleasurable feelings of using the drug with the cues in the environment that were there when they took the drug, they develop classically conditioned responses that maintain an addiction. They're associated with cravings. For example, I had a client who had stopped drinking but had persistent cravings. They simply wouldn't go away, and we were perplexed. Finally, I had him describe what he did during the day. We found out that every day he drove home from work, he followed the same route, passing a bar he used to frequent. He would see the brightly lit neon signs every day on his way home from work. These signs triggered the cravings because they were associated with the good feelings produced by drinking. He decided to change his route home, and the cravings subsided. Some individuals may have impairments in brain mechanisms controlling inhibition, leading to lower levels of self-control, and thus these individuals may be predisposed to substance use disorders. In the DSM-5, substance use disorders are differentiated according to the specific substance used, like alcohol use disorder, cannabis use disorder, and opioid use disorder. The DSM-5 no longer has a separate diagnosis called substance abuse or substance dependence. Abuse and dependence are now combined into what is termed substance use disorder, and individuals receive a diagnosis based on meeting 2 or more symptoms and then rated on a level of severity. For example, it's considered mild if 2 or 3 of the designated symptoms are present, moderate if 4 or 5 are present, and if 6 or more symptoms are present, this indicates a severe disorder. Again, severity is based on the number of symptom criteria present. If there is dependence, then the clinician simply adds a specifier indicating physiological dependence. Here's the list of the DSM-5 criteria for a substance use disorder, which can also be found in your text. These symptoms are assessed in screening instruments. And for example, you can see loss of control here, where the quantity of the substance used or the amount of time spent using is often greater than intended. And you can see it here. Use of the substance continues despite harmful effects. And loss of control is here. Continued substance use occurs even when the substance is causing physical or psychological problems. The physiological symptoms show up here in tolerance and also here where withdrawal symptoms may precipitate resumption of use, and substances may be used to relieve or avoid withdrawal symptoms. This chapter gives an overview of substances associated with abuse and puts them in 3 general categories, such as prescription medications, which are used to treat anxiety, insomnia, or pain. Prescription drug abuse has become a growing problem, especially in the elderly, and some recent data show an increase since 2002 in the overall number of people being treated for the use of pain relievers. Another category include the legal substances such as alcohol, caffeine, tobacco, and even household chemicals, which are huffed to get a high. And finally, the category of illegal substances such as methamphetamine, cocaine, and heroin. Alcohol fits into the category of legal substances, and it is important to note that it is a depressant. Depressants cause the nervous system to slow down. Even though many don't like the taste, they still drink alcohol to relax. Drinking can be defined by the amount used. Moderate drinking is a lower risk pattern of drinking, no more than 1 drink for women or 2 drinks for men per day. Heavy drinking, the drinking levels exceed the moderate level, of course, and binge drinking is defined as 4 to 5 drinks or more on a single occasion. Women tend to become addicted to alcohol quicker and easier than men because their bodies contain less water and more fatty tissue. Also, there is less activity of the enzyme that breaks down alcohol. So, one drink for a woman has the impact of two drinks for a man. The effects of alcohol abuse can be quite severe. Alcohol poisoning can occur. Alcohol has a chemical structure very close to that of ether, and at higher and higher doses, it eventually affects the autonomic nervous system and can result in impaired breathing, coma, and eventually death. Alcohol use disorder is twice as likely in men, but as I mentioned earlier, alcoholism progresses more quickly in women. Delirium tremens is a serious withdrawal symptom which is life-threatening. This can result in seizures, agitation, and hallucinations. Someone can die from alcohol withdrawal. One cannot die from heroin withdrawal, although they look quite terrible and they look as if they're going to die. But alcohol withdrawal is a medical emergency in some cases. Let's take a look at some other substances of abuse. The opioids are pain-killing agents that depress the central nervous system. Illegal forms are heroin and opium. Prescription pain relievers such as morphine, codeine, and oxycodone are also opioids. Opioids are highly addictive and produce both euphoria and drowsiness. And research indicates that many opioid abusers began their habit with prescribed opioids, eventually buying prescription opioids illegally or trying heroin as a less expensive and even more lethal opioid. Someone may be diagnosed with sedative, hypnotic, or anxiolytic use disorder. These drugs have calming effects, and they're prescribed to treat agitation, muscle tension, insomnia, and anxiety. Hypnotics are referred to medications used to induce sleep. Anxiolytics refer to medications that reduce anxiety. The benzodiazepines such as Valium and Xanax produce rapid anxiolytic effects in moderate doses, but they produce hypnotic effects in higher doses. And benzodiazepines are sometimes used to treat alcohol withdrawal. Now, sleeping medications disrupt the normal sleep cycle, making them difficult to get off of, and they can be highly addictive. We don't often think of caffeine as a substance of abuse. It is a stimulant found in coffee, chocolate, tea, and soft drinks. It is the most widely consumed psychoactive substance in the world. In North America, 90% of adults use caffeine daily. And it has withdrawal symptoms, and one can be diagnosed with caffeine withdrawal. These symptoms include headache, fatigue, irritability, and difficulty concentrating. Another substance of abuse is cocaine. Crack is a potent form of cocaine that is typically smoked. Because of its potency and the route of administration, it produces immediate but short-lived effects. Cocaine withdrawal produces lethargy and depression. Now, one rule of thumb is that the withdrawal syndrome is usually the opposite of the substance's effects. And individuals who use cocaine often have a shortened lifespan. The text covers some other substances of abuse, such as hallucinogens, dissociative anesthetics, and nicotine, which you need to be familiar with, and I'm not covering in this particular lecture. I want to discuss cannabis, and in particular marijuana, as one of our discussion questions asks you to reflect on marijuana use in our society. Cannabis is the botanical name for a plant that contains the chemical THC. THC is fat soluble, so it stays in the body for a relatively long time, and it can be detected in urine for even a month. THC can produce stimulant, depressant, and hallucinogenic effects, and the growing conditions affect the THC content. And marijuana is derived from leaves and flowers. Marijuana is the most commonly used illicit drug worldwide. 20 million adults and adolescents report current use, and males are more likely to use. Dependence produces a pervasive lack of concern over consequences, and also something called amotivational syndrome, or a lack of goal-directed behavior has been observed. Marijuana use does produce withdrawal symptoms, and I want to comment a little bit on the protracted use of marijuana. I do not believe that marijuana is a harmless drug. The THC in marijuana is just one of the hundreds of chemicals in marijuana. THC is stored in fat cells. The highest concentration of fat cells in the body are in the brain and in the genitals. When one ingests THC, that chemical remains in the brain and genitals stored in fat cells for some time. As I mentioned, THC is fat soluble. THC coats the cells of the brain and can interfere with the transmission of neural impulses. The ingestion of marijuana slows down these electrical impulses from one cell to another. So response time is slowed. Perceptions are altered. In fact, marijuana is classified as a hallucinogen due to this altered perception. Marijuana has been classified as a Schedule I drug by the FDA as one of the most dangerous drugs with a high potential for abuse and dependence. Other drugs in Schedule I are heroin, LSD, and ecstasy. A problem occurs with protracted use of marijuana, especially among teenagers who have a prefrontal cortex that has not fully developed. Use can be harmful in terms of the development of one's neural architecture. The prefrontal cortex is an important area for judgment and decision making. And this development is hampered because brain cells are coated and cannot function or develop properly. There can be long-term consequences even if one stops using marijuana. So I find one hard-pressed to say that marijuana is a safe drug. Just as excessive use of alcohol damages the brain, excessive use of marijuana can have dire consequences. We know a lot more about the effects of marijuana than we did in the 60s and 70s. And we know protracted use of marijuana has damaging and sometimes permanent effects on one's brain development and even sexual development and sexual performance. There are many political, legal, or medical arguments speaking to how we should handle marijuana as a society. A conundrum is a puzzle, and that is what we have today. One question everyone seems to be asking is marijuana addictive? From my experience working with clients and seeing the clinically significant impairment and distress associated with use, the answer is yes. Also, there are withdrawal symptoms, which can lead to difficulty stopping use, even in the face of legal consequences. Research shows brain changes. Some studies find only minor differences in brain structure and metabolism when smokers were compared to control groups. A new Australian study claims to have evidence that there are changes in regions of the brain that are equal to mild brain damage. Research suggests that medical use is beneficial. There is evidence suggesting that medical use is beneficial, but with it being a Schedule I drug, research is difficult to conduct, and this evidence at this point is mainly testimonial. The overcrowded prison system is another argument that's presented. Our prison system is overcrowded because of marijuana drug arrests. Pros and cons of legalization involve concern over DUIs, marijuana availability to minors, and whether it is a gateway drug. A final argument is that it should be legalized as a recreational drug like alcohol and tobacco. The best argument for recreational use is the comparison to alcohol and tobacco. But think of this. Alcohol and tobacco kill hundreds of thousands every year. Also consider that the potency of marijuana is increasing every year. In 2005, the journal Addiction stated that one joint was equivalent to a blood alcohol level of 0.05%. Now, sometimes people combine substances, and a serious danger lies in something called the synergistic effect. Interactions between substances intensifies effects. It is not an additive effect. In other words, 1 plus 1 does not equal 2. There's actually a multiplying effect or an exponential effect, as you can see in this equation. This leads to lethal overdoses. Some dangerous combinations are alcohol and tranquilizers, stimulants and sleeping pills, and alcohol and energy drinks. The FDA actually banned pre-mixed flavored alcohol energy drinks, saying the combination of caffeine and alcohol poses a public health hazard because high levels of caffeine mixed with alcohol masks the cues of intoxication. We still have much to learn about the etiology of substance use disorders, but a typical progression from substance use to abuse starts with a decision to experiment with drugs. Then the drug begins to serve important purpose. Consumption continues. There can be an obsession with using substances at this point. Then brain chemistry becomes altered from chronic use. This results in physiological dependence, withdrawal symptoms, and cravings. And finally, lifestyle changes occur due to chronic abuse. Individuals plan their day around obtaining, using, and recovering from the use of substances. The psychological dimension of the multipath model has provided some possible explanations for the etiology of substance use disorders. The major motive for substance use is coping with psychological distress and emotional symptoms. 45% of abusers have concurrent psychiatric disorders. One trait that is associated with substance use problems that appears to be emerging is called behavioral under control. It's a personality characteristic associated with rebelliousness, impulsivity, and risk-taking. It is important to note that research has been looking for the addictive personality type, or the alcoholic personality, and there's no such thing. Addiction is simply an equal opportunity destroyer of lives. Let's move on to look briefly at treatment for substance use disorders. 22 million people had a substance use disorder in 2012, and only 4 million are receiving treatment. And that is a sobering statistic, to say the least. Cost is a significant barrier for some. Managed care limits the days of treatment, and the days of the 28-day rehab seem long gone. To me, except for the rich and for the famous. Treatment occurs in supportive intervention settings, self-help groups, mental health clinics, and inpatient and outpatient treatment centers can all provide substance use treatment. Treatment for substance use disorders is most effective when incorporating best practices from high-quality addiction research. And research shows motivational enhancement therapy can be integrated with CBT and is one of the most effective short-term therapy approaches. There is a video in this unit explaining this approach, which addresses ambivalence about giving up substance use. Be aware of the appropriate medication to use for specific substance use disorders, such as antabuse or naltrexone for alcoholism and methadone for opioid addiction. And treatment basically has two phases. First, detoxification, and the second phase is preventing relapse. Unfortunately, relapse rates for people in treatment are high. Many people find participating in Alcoholics Anonymous an effective way to recover from alcohol use disorder. AA regards alcoholism as a disease and advocates total abstinence. Its philosophy is based on the disease model, which says some people will lose all control over drinking once they take the first drink. Therefore, since alcoholism is a chronic, progressive, and fatal disease, the only way to recover is to abstain completely. AA prescribes 12 steps that people must take toward recovery. AA groups provide moral and social support, and members make themselves available to each other in times of crisis. Another idea is called controlled drinking. The idea here is that under the right conditions, people can learn to limit their drinking. The trick is to determine which individuals this might work for. Otherwise, you are courting disaster. The bottom line in the treatment for alcohol use disorder is more research on treatments is needed. This chapter concludes with a look at gambling disorder, which is a compulsive desire to engage in gambling activities. It's diagnosed when a person exhibits at least 4 defining characteristics in 12 months, and it may be mild, moderately severe, or severe. And it is relatively uncommon, with a lifetime prevalence of less than 1%. Various treatment approaches include group therapy, CBT, and improving financial management skills. In treating gambling disorder, therapists should be aware that distortions in thinking may be present. Many with this disorder believe that money is both the cause and the solution to their problems, and they tend to chase their losses, not understanding the objective probability of winning. They may think that the longer their losing streak is, the closer they are to winning, which is called the gambler's fallacy. Individuals with gambling disorder have high rates of other mental disorders such as substance use disorders, depressive disorders, anxiety disorders, and personality disorders. And men are more likely to develop this disorder. Finally, up to half of the people in treatment for this disorder report suicidal ideation, and about 17% have attempted suicide. In conclusion, some areas of research focus include trying to better understand risk factors by studying individual and environmental circumstances that increase risk. Also, ways to counteract media and social media messages of the acceptability of substance abuse are being studied. And finally, we are trying to learn how to help parents more accurately estimate their children's alcohol use and enhance communication. And this is the topic of our second discussion question this week, and I'm looking forward to your ideas on how parents can better communicate with their children about alcohol and other drug use.